So thank you everybody for joining us today, and especially as today is Eid, we wish those who celebrate Eid Mubarak, especially given the time at the moment that people can't spend together with their loved ones. So just before we start, we have a few housekeeping details to share. This program is being recorded today, and the link for the video will be available within a few days. The recording will be shared via email and will be posted on our websites, and continuing education credits will be available. And when today's webinar concludes, you can click on the evaluation link in the description below the video and the window to obtain continuing education credits. We also are asking that if you have questions, you please enter the questions into the chat. Try to confine this to questions so that hopefully we can include your participation and address your questions. So I'm Valerie Luyckx. I am a nephrologist. I am an affiliate lecturer at the Brigham and Women's Hospital at Harvard Medical School in Boston, as well as an associate professor with at the Red Cross Children's Hospital at the University of Cape Town, and currently working at the Children's Hospital in Zurich. And I have the pleasure to moderate this session today. And this session essentially today is going to be focusing on this concept of decolonizing global health. The COVID-19 pandemic has brought many issues in global health to light. Much of global health has been considered health research or healthcare practiced elsewhere, most often driven by individuals based in the global north, in settings in the global south. And over the past year, given the recognition of the necessary reckoning with persistent social and structural injustice globally, there have been increasing calls to decolonize global health. Most global health organizations run out of high-income countries, mostly by men, with staff dominated by people who are mostly white from high-income countries, and they often control the purse strings and control the agenda of public health and global health. There is a quote that I found quite inspiring for this particular conversation today from Simu Kai-Chigdu in The Lancet, published in May 2021. And he states, "The paradox of global health is that it is sustained by the very inequalities it purports to alleviate. The only way out of this conundrum is to cut to the core of global health's foundational conceit and think anew its philosophical assumptions, organizational structures, practices of knowledge production, and imagined futures from the perspective of the formerly colonized." So I myself ask myself, how can I contribute meaningfully and be constructive and not perpetuate the status quo? I think we're all at a different part along this journey. Some of you may be hearing this concept of decolonizing global health for the first time. Others of you might already be racking your brains and your hearts about how do I participate in moving this forward. So today we're inviting you to join us in the conversation. We have three young leaders in this field who have all written extremely interesting pieces on this topic. And we're hoping that we will just open the field, open thought processes, and encourage discussion on this topic. So I think to start, I will invite Dr. Miriam Fofana to give us some background. She is originally from Côte d'Ivoire and spent most of her childhood there, as well as a few years in Kenya before moving to the United States. She's a physician with specialty training in emergency medicine and a researcher with a doctorate in infectious epidemiology. Her professional interests revolve around infectious diseases, quantitative epidemiologic methods, global health, medical education, and ethics. And she's especially interested in making global health more equitable and sustainable. So welcome, Miriam. Thank you for joining, and we're looking forward to your contribution.
All right. Thank you so much, Valerie, for that introduction, and thank you everybody for being here. I'm really glad to welcome so many people with interest with this topic. And what I'd like to do is, give a little bit of an introduction, as we know that we're all starting perhaps from different places on this particular topic. And what I want to explore is the question of how and why global health is colonial and why this needs to change. I'll give just a very brief disclosure that nothing that I say here is, set in stone. Nothing that I say is the gospel truth, so to speak. And also the caveat that I am speaking here as somebody who has spent her entire higher education and professional career in the United States. which obviously colors some of my perspectives and experiences. So I'd like to take a little bit of a trip back in time and explore the origins of what we, call global health, which is this, vast and sometimes quite ill-defined array of disciplines and pursuits. So if we go back to the late 19th century, when European nations are very aggressively expanding their colonial empires, about the same period, there's also some new discoveries into the microbiology of disease by people like Louis Pasteur. And there's a combination of these two movements, these two historic developments, that creates what was known then as colonial or tropical medicine. And this was really largely an enterprise that was meant to support the colonial enterprise, to benefit these wealthy European nations by protecting the health of the staff, essentially, that they had to manage the overseas colonies. And so the centers of training, the intellectual center of power, the centers of financial and legal and administrative control were all in the colonizing nations. And then during the 20th century, this morphs a little bit as juridical colonization ends, but there's the birth of something that comes to be known as international health. And so there's a continued effort to eradicate infectious and so-called tropical diseases, largely led by philanthropic organizations. But the term itself really reveals a lot of the inherent constructs and biases, right? When we're saying international, it begs the question of international with respect to whom. And in this case, again, like in the case of colonial medicine, the center was in the colonizing or formerly colonizing nations. And there's a recipient or donor side, if you will, that is largely formerly colonized countries or otherwise countries of what is now known as the Global South. And as much as international health was viewed as a philanthropic and kind of benevolent endeavor, it still was really structured around supporting European and American corporations that were continuing to exploit these formerly colonized nations. And then in the 1990s, spurred in part by the HIV epidemic, there's a shift in language to global health. There's an implication in the term of this interconnectedness of the world. People can fly from one end of the world to another. As we well know and are acutely aware right now, the diseases know no borders, especially for infectious diseases. And yet, despite this term, which seems to evoke a sense of unity, there are still the same structures that persist from the prior eras of international health or colonial health. And so again, the centers of power, the centers of decision-making, the centers of funding tend to be in high-income global north countries, with the lower income, formerly colonized global south countries being on the recipient side. And for that reason, in fact, historian Randall Packard titled his book about global health, Interventions into the Lives of Other People. And one thing that we have to think about when we think about these patterns is what privileges persist that are a result of colonialism and the colonial era. So for example, for anybody interested in or working in global health, there's a lot of privilege that could come from citizenship, right? And especially, for example, what kind of passport you carry, the color of your passport can dramatically affect your ability to travel, to seek out certain educational or professional opportunities. And so overwhelmingly, people in high income countries get to travel quite easily to low and middle income countries, but experts from those low and middle income countries will see themselves being denied, even short-term visas to European or North American countries, even when they're specifically invited to share their expertise. So a lot of the important events where knowledge is disseminated, where decisions are made, are attended primarily by people from high-income countries. They are held overwhelmingly in high-income countries, which makes them exorbitantly expensive and resource and time-intensive to attend for people from the global south, especially when those costs are so disproportionate to the average income in one's home country. And there are things that are perhaps less tangible. So institutional resources, credentials, and reputation that are attached with certain institutions, academic degrees, the professional networks that give you access to opportunities are very inequitably distributed. We can even think of something like language, the fact that we're holding this seminar in English, which is overwhelmingly the dominant language in the world of global health. But what does that mean for people who do not speak English or do not have a native or proficient, native level proficiency? So you end up losing access to opportunity, and you simply just do not have as much voice. You don't get to participate in the important decisions. And these patterns of privilege are very deeply embedded in the culture of global health. For example, do we think that most global health work is benevolent, or do we perhaps recognize that even when there are good intentions, our work can replicate or perpetuate inequities? When we think about whose work is valued, who gets seen as an expert, who has to, who gets certain privileges, who is deserving of, certain remuneration, for example. When it comes to our practices, right, again, who gets recognition, who gets funding, who gets career advancement, who gets to have a platform or participate in the important scientific or policy discussions. Now, there are steps that each of us can potentially take as individuals to change the culture and practice of our microenvironments. Some of us have more influence than others. And for some of us, it's going to be primarily a personal, individual change. But I think the most challenging part, the most challenging thing to change are really these structures and systems that are so deeply entrenched. Who has the power to influence research agendas or funding streams? And the COVID pandemic has really put this in a really enraging and heart-wrenching light. Who designs the laws and regulations around intellectual property? Why do northern countries view themselves as charitable when they're donating trivial amounts of vaccines, while at the same time they're hoarding large quantities that are, they're letting them expire? They're impeding countries in the global south from developing their own production and distribution infrastructure. So obviously, we as individuals are likely to have little influence on those things for most of us. And so, there's been a lot of thought, as Valerie mentioned, around, how to decolonize global health and what does it really mean. I offer here a few definitions that have been offered by various people. So Abimbola and Pai, for example, suggest that it is to remove all forms of supremacy within all spaces of global health practice, within, between countries, and at the global level. I like the second definition, that the flattening of entrenched colonial era power hierarchies, because it really recognizing that the global health in its current form still functions amidst this system of hierarchies of knowledge and culture that are directly derived from colonization. And then the last one, I think, really asks about whether you can decolonize something that would not exist without colonization, right? And says that we would have to have a radical redistribution of funding, a loss of epistemic and political authority in the global north, and a limitation of power for the global north to intervene in low and middle income countries. And so one thing that I just to kind of sum things up and perhaps bring this thought to you, something to chew on. I'm inspired by this quote by one of the leaders of the Zapatista Liberation Army, who at one point said that the highest goal of his army was to disappear. And I think similarly, the ultimate goal of global health should be that it becomes obsolescent and is replaced by something new and more equitable and more sustainable. So with that, I will give you a list of some of the references that I've mentioned here. You may also access them by scanning the QR code. Thank you very much for listening, and I'm looking forward to hearing from the other panelists.
So thank you very much, Miriam. That was a huge amount of food for thought. That's a wonderful way to begin. And so now we will switch to the second speaker, who is Shanaz Munshi. Shanaz is a health policy and systems researcher, an occupational therapist, and an emerging voice, and senior Atlantic Fellow for Health Equity at Takano. She's currently the project manager for the Shayam Family WITS program on social determinants of health and health equity at the School of Public Health in the University of Witwatersrand in Johannesburg, South Africa. And she serves on the steering committee of the People's Health Movement. And Shanaz is hopefully going to take us on the next step into this journey. Welcome, Shanaz.
Hi, everybody. Thank you so much for having me. I'm going to share my slides. I hope that you can see them and that they're clear. So thank you, Miriam, for providing incredible food for thought and for taking us into the past, the history, and allowing us to kind of understand that where we come from has a resonance with where we are today. So I am going to try and move quite briefly through my slides because you've covered quite a bit of what I was going to say, but I'd like to start with a quote by a decolonial scholar, Puerto Rican scholar, Ramon Gross-Fugal, who talks about the myth of the post-colonial world. And he says that the most powerful myth was the notion that the elimination of colonial administrations amounted to the decolonization of the world. The heterogeneous and multiple global structures put in place over 450 years ago did not evaporate with the judicial-political decolonization of the periphery over the past 50 years. We continue to live under the same colonial matrix of power. So this is the kind of calling and a wake up that what is this that we're living with? How deep is it? Where does it go? Where do we find it? And with that, how do we begin as public health scholars, as global health scholars, however you define it, what is the important terminology for us to start grappling with and understand as we go on this journey? And a lot of this knowledge can come from decolonial scholars who are offering us a way of thinking. So I want you to have a look at this drawing, this image, where you see a scholar at Rhodes University, the university formerly known as Rhodes, in a little place called, formerly known as Grahamstown, a colonial place where a westernized university built on the structure of Cecil John Rhodes, a former colonialist, built his university as a way of bringing forward replicas, which is basically all of us, into the colonies. And here we have, a few years ago, women and men in South Africa, students, crying out that actually we need a decolonial movement. Rhodes must fall. We need a new way. We need a new epistemology. We need a new way of thinking. We need a new ontology. We need a new axiology. We need new ways of being, ways of doing, ways of showing up, ways of thinking from a very deep philosophical point of view of how do we imagine and think about being in this world. And so coloniality is a term that Ramon Gross-Fugal is describing, this condition that remains prevalent with us today. He says it, another Zimbabwean decolonial scholar, Sabelo Ndlovu-Kacheni, talks about coloniality as a condition that survives beyond colonialism. And it's an invisible power structure that sustains the colonial relationships of exploitation and domination. And we kind of breathe in this coloniality every day. So what is this colonial matrix of power? It's kind of an organizing principle of colonization. They look like racism, heteropatriarchy, and capitalism. And Ramon Crossfield has an interesting definition of racism that I'd encourage you to go and look at. There are various definitions of racism, and these include xenophobia, Islamophobia, and all forms of migrant discrimination, then heteropatriarchy and capitalism. And our job or our role in the health sector is to see and try to understand and unpack where these matrix of power operate and exist in our ways of being and doing, which include research, which include all the policy making, include delivering healthcare, and so on. So these principles interact and intersect with each other. They build on power asymmetries in all areas of life, where, especially as an African, our lives are often compared to the white superior other in the North. And it results in economic disposition. As you can understand, as an African, our continent is rich in mineral resources, yet we are the poorest. And this project is sinister. It claims to be a civilizing project, but we need to look at them as structural determinants of health. Now, these principles can inform a decolonial framework of thinking to help us develop a new lens to disrupt these ideas. And so what can we do with this lens? So we firstly argue that the injustices in the world is rooted in the colonial project and coloniality. Then we need to develop a kind of systemic and structural understanding of where they are entrenched. Now, this I'd encourage, it's a long haul. There's no magic silver bullet. And part of in my training, both as an occupational therapist and in public health, we quick to come up with recommendations and solutions. But here, we've got to maybe rethink the ways we do things and realize there's no single story. It's a complicated situation, and we've got to sit in the problem a little bit longer before we can start to see how and where the ways out of it come. We need to politicize our research and see it as a tool and as part of a social justice agenda. And that means we need to act and disrupt coloniality. So the question again is for you and me, how does the past live in the present moment from my positionality? And what does the disruption mean for me for public health? Am I going to join this revolution? Am I prepared to disrupt? Am I prepared to distribute my economic, financial, intellectual power? And it does require a measure of reflexivity in the ways in which we be and do, and to examine. And if we look at this picture, how far are we from this image, and how is it reimagined itself in different forms? At what point do we wear these safari hats and come forward with our examining eyes, with a kind of sinister motive, or even a really human rights agenda, but that it's got other agendas on the side, and some of them don't look at in the form of maybe dispossession, but maybe intellectual property, getting a publication, getting a promotion. So we need to examine ourselves. So another important term is decoloniality. And for me, that is a political, epistemological, economic liberation project aimed at dislodging coloniality and its manifestations. It's a practice, it's a way of being and doing. So that's why I mentioned the word revolution. It's an ongoing project. It's a conscientization project. It's about disrupting, delinking, disentangling. Ultimately, we don't want to be in the same situation. We want to be liberated. We want to reclaim our identities, rebuild, co-build our ways, ways that are socially just, and really bridge a lot of the inequalities that exist. And so again, we need to dive deeper because there are layers and layers. And we need to understand, well, how does it manifest? How do the matrix of power manifest in our structures and systems? And they do in the forms of coloniality of power, of knowledge and being. Of power, it's really around the technologies of domination and exploitation. I sit in a university in the global south. Harvard is a university in the global north. There are technologies that exist or between the two situations and the two places. And this is something, and even the WHO and other places, the global architecture needs to be examined. Coloniality of knowledge is really around thinking about the domination of knowledge. Where is knowledge produced? How do the publication systems work? Why is there a dominance of northern researchers over southern researchers? The legitimacy of knowledge. Why is Western knowledge more important than the knowledges that come from the East or come from the South? And what about this coloniality of being? And I think for me, this is probably the most devastating because it's the denial of humanity of people. It's the process of inferiorization and dehumanization. And usually it's the othering of colonized compared to the white subject. So I'm gonna stop there and I will continue the conversation later when we discuss, where I have some I'd like to share, maybe just deepening the thinking within the health system of how to think about perhaps, and I'll introduce the word, the fact that our systems are actually not conducive to the people that it serves is actually perhaps we need to recognize that our health systems, especially in Africa, are structurally violent institutions that were built in a historical pattern. And when we see these complex arrangements like anti-Blackness, racism, segregation, economic inequality, climate destruction, gender inequality, and now the vaccine wars with COVID-19, there are strong associations between racism, heteropatriarchy, and capitalism, where our health is commodified, that should make us angry. It should actually make us wonder, why have we made this kind of situation that we're living in normal? How is this our norm? And what are we going to do about it from this point? Thank you so much.
Okay. Thank you, Shanaz. That's a very provocative talk, which is great. And now if you could unshare your screen. And now I will invite Desmond Jumbam, who is a Cameroonian health policy analyst currently based in Accra, Ghana. He currently works with Operation Smile, which is a cleft NGO operating over 30 countries. He specifically advises and leads the organization on a portfolio of health system strengthening projects focused on strengthening surgical care access and delivery in low and middle income countries. He was previously a health policy analyst with a program in global surgery and social change at Harvard Medical School, also advising on national surgical policies. He's the co-founder and president of the Jumbam Family Foundation, which aims to support communities adversely affected by ongoing civil war in Cameroon. And he holds an MSc in global health from the University of Notre Dame and a BA in biological sciences from Taylor University. And so, Desmond, we're very happy to have you now to bring some of this together, hopefully.
Thank you, Valerie, and Shanaz and Marian for introducing the webinar. It's a pleasure for me to be here to talk about this topic that I've become very passionate about because it's one that is very important. So what I'm going to do is take a bit of a slightly different approach. Mariam and Shanaz have shared some of the historical background behind coloniality in global health. But I'm going to try to give some practical examples of what that actually looks like within the global health space based on my experience. And so I think it makes sense to tell you a little bit about myself. again, as a disclaimer, I was born in Cameroon. I grew up there. I had the opportunity to study in the United States, where I got my bachelor's. And then I further went on to get a master's in global health. That was my, at the University of Notre Dame in the US. And that was my first exposure to this concept of global health. I had the opportunity to travel to Zambia and conduct some research on malaria there. I've also had the opportunity to work with other research institutions like the program in global surgery at Harvard Medical School, which I've benefited a lot from. And now I work for an international NGO. So I again give that just so you know my perspective. I am from a low and middle income country from the South, but I do have some privilege of studying and working at institutions that are based in the North. But given my experience, I think it's important to acknowledge some of the wonderful things that have come out of this thing that we call global health, whatever we call it. There's programs like PEPFAR and that eliminates is working towards HIV treatments and has led to significant advances. There's reduction in malaria and child mortality and polio eradication. So there are all these wonderful things that have come out of this thing that we call global health. But I also observe some things from my experience that are very discomforting about these things. Again, this concept of global health, everybody has a definition. And Mariam and Shanaz have touched on it a bit. So one of the things that I noticed is, it seems to me that, as Mariam said, even though the name has changed, we went from colonial medicine to international health and now to global health. Even though the name has changed, there are still some kind of underlying perpetuating colonial systems that persist, systems of power asymmetries that persist in global health. And I'll give some examples of that, again, looking at, within the research space, within the NGO implementation space, and within the education space. But it also seems to me that this neocolonialism, if you would, within global health is a bit more pernicious and harder to address, because unlike colonialism that ended in the 50s and the 60s, there is no territorial invasion. There are no administrative, powers that still are in these countries, but the power structures that were set up, the systems that were set up, continue to exist. And I think it's, again, much like institutional racism in the US. It's not a white hooded person, that we're addressing, but there are systems that have been embedded and continue to perpetuate itself. And so let's look at first research. My observations. It seems to me that and I think this is not just me, because there have been calls for decolonization of global health from numerous people in low middle income countries, but there are still power asymmetries that exist in the research space. So, for example, most of the research priorities within what we call global health are still primarily determined by researchers and funders from the global North, from the United States, and big organizations like the Bill and Melinda Gates Foundation, Wellcome Trust. Many of those still determine the priorities for those in communities in low and middle income countries. And the problem with that is oftentimes those practicing there are not sought, their inputs are not sought on the types of problems that they would like to address. Researchers from low and middle income countries are primarily still seen as data collectors. So oftentimes, a researcher from the North will have the funds already available, the ideas already available before they reach out to someone in that community. And by that time, it's the funds are already available. And so it's a kind of a self-perpetuating system, and it's created, something that others have called the little brother effect, where researchers from low and middle income countries are still seen like beneficiaries as opposed to partners. And that extends also to the dissemination of this knowledge that comes out of global health research. So most of the research that is done in communities are published in the North, oftentimes behind paywalls that those researchers and policymakers in those communities will never have access to those published articles. That extends also to global health conferences that are happening in Geneva and in New York and in Chicago and wherever. There's research presented in, for example, Tanzania, that the Tanzanians don't know about their communities. And so it again perpetuates these ideas that those in the South are meant to be beneficiaries of knowledge. It takes away from the local knowledge that is there. It discredits or doesn't give due credit to those who are in those communities working hard, looking for organic solutions to health problems. I'll quickly touch on global health education, because I noticed a lot of global health programs, especially masters in global health programs that are popping up, most of them in high-income countries. Again, the challenge with this is most of these programs are based in the North and they're very expensive, which makes it harder for those from the South to be a part of. And the thing with that is, again, many of those who go on to attend these programs, they tend to occupy positions of power within the global health space, WHO directors, and they make the decision for where the priorities should be set. And if those from low and middle income countries don't have these opportunities, it again is deeply problematic. And finally, just to touch a little bit on the NGO space, I find that there still exists this supremacy, which ties to the funding, that a lot of the funding goes to international NGOs that are based in the North. Even when there is capacities for program implementation in the South, most of the funding still is not available for those programs in the South working within their communities. So the question for all of us is, how do we dismantle these power asymmetries that still exist? And I usually like to close with the question that, what are you willing to give up for justice and equity? Because something has got to give. And we're in this together. Everybody has a role to play. So thank you very much.
So thank you, Des. That was great. And I think all three of you, it's taken a little bit of time to set the stage, but I think it's critical, because I definitely think hopefully we're all at least now thinking. There've been some very interesting questions, and I think the three of you can feel free. You can put all your cameras on, and also please, just to remind people, if you do have questions, please put them in the chat and we will try to get to them. But Desmond, you can put your camera back on, because now we're going to try to discuss a little bit. Some people have asked, well, there was a Dr. Somo Mukhopadhyay, hopefully I'm saying that correctly, asks a very good question. Are we looking at colonization from the more racial point of view or the economic point of view? So that's one question. And then some other questions are really about what are some of the initiatives that might already be in place to try to improve the current situation. And then we can discuss a little bit more about funding and publications and things if we get to it, but there is some literature already. So I think this question of, are we looking at it from racial point of view or economic, is very interesting. And then potentially each of you can maybe make some comments, and then what opportunities do you think there are? How can we start to move forward? Would you like to maybe start, Miriam? Could you unmute?
Sorry, Zoom struggles. My answer to the question would be that the two are inextricably intertwined. And I think it's quite there's a quite ready parallel when we think about institutional racism in wherever you want to think about it. It exists everywhere, but thinking from my perspective in the US, right, racism was enacted through economic policies, and the continued economic dispossession feeds into racism. You can't fully unlink the two. And when we think about it in the global health arena, economic power has to be part of the equation, right? And again, I will bring up the example that we're living right now, that economic power is creating, all these separate worlds now, such like different experiences of the COVID pandemic. Where I am right now, people were thinking about, oh, we're going back to normal. School is opening up. Nobody's wearing masks. You don't have to wear a mask if you're vaccinated. And in the meantime, there are people who are yearning for this vaccine, who don't have access to it because their countries have been plundered, right? And even when they do have the money that they want to buy the vaccine, somebody else is making the rules that, oh, actually, you have to get them through charity and you can't produce your own. So I really think the two are perhaps really one and the same.
Great. And Shanaz, maybe a quick answer.
Yeah, so I think that in answering that question, we need to go back to thinking about what was the goal of the colonial masters and what did they do? And they had technologies of domination. And there were many technologies of domination and control and exploitation that they used. So racism was just one of the technologies of domination. They dominated even sexual reproductive health, sexuality, by class, by gender, by religion, by language, by military, by epistemic, ethnicity. There's a lot of technologies. So it's not about one, but yes, to add on to what Miriam is saying, is that everything is inextricably linked, and a lot of it had to do with trying to dominate in order to gain money, in order to develop the home country, and leave the colonies left with very little. And that situation remains today, and this is the deep unhappiness and what we need to start changing. Thanks.
Thank you. And so I think there's obviously healthcare that's happening. There's health research, and then there's obviously all these economic overlays. So I think it's very, very complex. Des, would you like to comment on either of the questions, the question about opportunities or the question on what the underlying sort of race versus economics?
I mean, I agree with Miriam and Shanaz. It's hard to separate both, because in addition to the systems that were set in place to obtain money, there's also the issue of power, right? So it's whatever tool that will be used or that is useful to maintaining power, right? In this case, as Shanaz has pointed out, there is race that is used, but then there are also economies. I mean, it's quite clear with the vaccination issue, nationalism of vaccination, that we're seeing that economics has a lot to play with it, because it seems to me that ultimately in the end, the countries will look out for their own benefits before looking out to other countries or to things like equity. So I think both of those are very intricately linked to maintain power where it's at.
And so I'm just thinking now, if we discuss a little bit about opportunities, there's a question here from Dr. Tucker about our journals making accommodations regarding charges for publication, allowing more publications. What I also wonder sometimes is sort of tokenism, allowing certain people to be, where are the local authors? So I wonder if any of you could discuss a little bit about how you think we should potentially be changing the funding system and the publication system, the actual conduct of the research, so that local expertise can really have a fair shot at, being showcased the way sort of higher income research is showcased?
Well, I could probably give a few points on that. I think a lot of quote unquote global health journals seem to be making much progress in that. You know, there are a lot of guidelines around, you know, if you're going to be conducting research in a particular community, you have to make sure that there are authors included from that community. And with regards to publication charges, you know, there are a few journals that, you know, waive publication cost for researchers from low and middle income countries. And so I think that's you know, a good first step. But I also want to challenge researchers from low and middle income countries about how we can raise the, you know, support our own local journals, you know, to increase the capacity in such a way that, you know, we're not having to look to, you know, these journals that have all these, you know, publication costs and have all these barriers for our own people to access that journal. So, you know, we have to ask ourselves the question: how do we support local journals, you know, publishing more in them and trying to get their visibility and the amount of impacts that they can have. I understand that as a researcher, you obviously want to publish in a high impact journal. There's so many incentives to do that, but we have to ask ourselves, you know, what should we sacrifice in order to elevate ourselves at the, you know, in the South.
And if Mariam or Shanaz, you'd like to add, I think one of the other questions is, who are all the actors that we haven't yet discussed? Maybe Mariam, would you like to maybe discuss or mention that? Just unmute again.
I apologize. I think perhaps that's a bigger question than I can answer here. I think, you know, again, because global health is covers so many different, you know, disciplines and endeavors, there are lots and lots of people involved in various ways and to varying degrees. Perhaps what I will mention is the challenge that I've experienced personally, and I think is perhaps shared by a lot of people who identify as being in the diaspora, or who in some way, shape, or form have benefited from the privileges bestowed by these colonial structures. And I think, you know, it is perhaps part of the definition of being in the diaspora is that you're going to wrestle with identity and belonging. And I think it can be a difficult position, especially when one yearns to be, you know, accepted in one setting or other, and finds oneself not quite fully belonging, or not belonging in the way that we would hope. It also offers opportunities to kind of act as a bridge. I mean, you have the privilege of seeing things from multiple perspectives, of understanding some of the tools that you have access to that perhaps others don't. Understanding some of the needs that perhaps some people with the tools don't understand. And, you know, creating that bridge, trying to manifest that in your own work, but also thinking about how do you shift all of that power, right? Because ultimately, I should not be the person speaking about, you know, decolonizing global health, right? But perhaps I can use my time and my voice to get people to think differently, or to start thinking differently. And that perhaps will help give a platform to somebody who's really the person we should be listening to. So I think we all have some opportunity in that respect. I appreciate what you were saying, Desmond, about, you know, what can be done from the global South. And I think one of the really perhaps most pernicious effects of colonization is when it becomes internalized. And when, as a colonized people, you start to value what comes from the colonizer more. And I have had, you know, some experiences that were quite discomforting to me, as a graduate student, trying to establish some work in my home country of Cote d'Ivoire. One thing was that I was coming from a US, so English-speaking university, and there were so few relationships existing. And most of the people that I could work with in Ivory Coast had existing relationships with researchers in France, which is the former colonial power. So you see these relationships, they have a deep impact on how global health is practiced. Another thing that I noticed is that I wanted to be, an Ivorian researcher, but I was treated differently. The way that people received my ideas, how I was listened to, how my ideas were valued, how my competences were perceived, was not the same way as it would have had I been, a student in a local university, and that's profoundly unfair. And I have to think about, for example, when in these relationships that exist between researchers in Ivory Coast and in France, some of my Ivorian colleagues, when they travel to France, they figure out their own housing, they figure out how they're going to get to the airport to wherever they're staying. When their French colleagues come to Ivory Coast, somebody's always there to pick them up from the airport. We always make sure that they're staying in a nice hotel. Their housing is arranged for, their meals are arranged for. So how have we, in the global South, are these, hierarchies internalized into who we think deserves certain treatment, who deserves certain respect? And that's going to be very challenging, and it's going to require breaking some of those ties that that have been enduring, and perhaps thinking about, should we maybe not collaborate with the former colonial power? Why don't we collaborate with colleagues in South America, and think about how, from our different contexts within the global South, we might learn from each other. Valerie, you're muted.
So thank you. That's also a wonderful perspective. So I think, unfortunately, we really only have time for a sprinkling today, but I think definitely a lot of food for thought. We have literally probably 5 or 6 minutes left. I'm wondering, Shanaz, if you would like to make any comments on what has been said already, or mention anything that you think we haven't touched on yet?
Yeah, I think what I will talk about is the Africa Health Futures Project, which really is about consciousness. It's a consciousness project that tries to recognize and resist these narratives that were just brought up. Ultimately, what the Colonial Project was trying to do is to delegitimize Africans as knowledge holders, knowledge creators, knowledge bearers, especially in health, especially around care. And there's a history of trying to make Africans seem, especially you could see it around Ebola, as people that carry these viruses that are going to travel to the north, and so we need to close our borders, and it becomes another way of othering and alienation. And it was quite interesting with COVID-19 when Europe and Italy and America was initially, quite affected by COVID-19, to actually disrupt some of these subconscious, unconscious biases that we have around the African body. And I think that what we need to do is reclaim. We need to reclaim ourselves. We need to reclaim our dignity. We need to reclaim a sense of self-respect as Africans. And we need to disrupt these narratives that, in order for us to write about Africa in a health journal, we need to write in a way that is palatable for the Western gaze. So we actually need to write our stories for ourselves to be consumed and debated with by ourselves. And we need to shift the power and reclaim what is ours, so that we're not looking for validation and affirmation from the global north, but that we see our own scholars like Sylvia Tamale, like Stella Nyanzi, like Sabelo Ndlovu Gacheni, like Pumla Kala, many feminist scholars, many decolonial scholars, and let's hold them in esteem and quote them and bring voice and space to these scholars to show us the way forward. We have the answers here. We just need to take the time and shift the power. And perhaps, last year we had a conference where Pascala Lotti asked us at this African conference, how brave are we to really disrupt the quest, in the quest for decoloniality? How brave are we? Because part of the bravery means saying no to money that may come for that grant. Because when you look at the details of the grant, it means you cannot be a co-author, you cannot be a knowledge bearer, you cannot be part of that. You have to hand over a lot of power. So sometimes it means we have to say no, and we have to be brave enough to make these decisions as Africans so that we can claim what is ours. Thank you.
Okay. Thank you very much, Shanaz. And I think we are unfortunately reaching the end of this hour, which I think has been extremely interesting. I think hopefully we've all understood that this idea of global health involving other people is not correct. It's involving people like us everywhere. This idea of considering our own privilege, being humble, trying to understand what should or could we give up in order to try to improve and be more transparent, be more fair, be more inclusive. I think this is definitely a big question for people working in academia in the global north, because a lot of their careers are dependent on grants and funding, etc. Funding agencies also need to think about how to radically change their structure potentially. We need to think about how we can also speak up potentially when we do see that there are opportunities, and how we can all together collectively over the long haul here try to contribute to sort of the rebuilding and I don't want to use the word but how we can really all try to generate this global community where we can all share, because I think there is value in sharing knowledge, there is value in sharing expertise, there's value in sharing resources. But sharing is probably for me one of the bigger questions. So I think we are pretty much almost at the end. And so just to remind people that attendees can gain continuing education credits for participating in today's session. To do so, please click on the link in the description below the video window to complete the evaluation and obtain credits. This information will also be distributed through a separate email to today's participants, along with links to a recorded version of today's discussion and credit information. The email will also include additional HMS COVID-19 resources. And please distribute this to colleagues that you feel would benefit from this information. And thank you for joining us. And I think just again, if I have a few moments, or if any of you has something really pressing to say, please go ahead. But I think COVID-19, hopefully, together with the Black Lives Movement and all the distress that we've really observed over the last year and a half, should be enough to energize us and galvanize us all to try to work collectively for change. Anyone has any burning statements to end with? Des, you're smiling.
No, just to affirm what Shanaz has said. How brave are we? There's some bravery that is going to be needed. What are you willing to lose in your partnerships? And I think it's a question for us in the South. What are you willing to lose? But also in the North, in order to dismantle this system. So we all have a role to play. So I agree very much with you, Shanaz. We need to be brave. We need to consider what we're willing to lose.
I'd just briefly like to thank everybody who participated, and thank especially Desmond, Shanaz. I've learned a tremendous amount from you both.
And Shanaz, you
likewise, Miriam.
I've also really enjoyed this conversation and learned a great deal, and I appreciate the opportunity to be here. Eid Mubarak to all those who are celebrating, and I really hope that we can rebuild, re-envision, I guess, maybe, and just imagine and activate our imaginations to build a future where equity is at the heart, and health is a human right, not something that we have to wait and buy or commodify. I look forward to a world that in the future. Thank you.
So thank you. For me, it was really a privilege to learn from all three of you. I'm just really here as the moderator. And I think, Miriam, you did have some references at the end of your slides, and maybe we can collate some extra references and be able to share those as well, because I think there is quite a rich discussion that's been happening in several of the global health journals, especially BMJ Global Health and the Lancet Global Health and various others, PLOS One, etc. And I encourage anyone who's interested to look this up and to engage in the conversation. So this has really been a big privilege, I think, for me and hopefully for everyone. And yeah, so if everyone just remembers, if they want to get the credits, please click the links and hopefully share then the video, this YouTube video, and hopefully amplify the conversation as well. So it's really been a very big privilege for all of us. Thank you very much.